Today we get into the discussion of the adaptive immune system. And this is going to be one of those topics that is going to sound very foreign the first time you hear it. As much as we know we've had problems in class understanding cardiovascular and respiratory, at the very least, those were systems that you could throw around the terminology at least a little bit from a layperson's perspective. The immune system, especially the adaptive immune system, always seems like a very abstract concept the first time you go through it. So because of that, I normally recommend before you listen to the lecture, skim through the notes that are provided first. Then watch the lecture once without the intention of taking notes. Just kind of absorb what you can. Then watch the lecture again. The main reason I recommend we do it in that way is that we're going to be, overall, we do have a plan of attack on how we're going to look at this system. But you'll see some terms and some cells thrown out early on in the discussion that we haven't really defined yet. Because it's not like we can compartmentalize all aspects of this topic and knock them off one at a time. We kind of have to understand the adaptive immune response as one big ball of wax. And I think if you tackle it in that way, it will make just a little bit more sense. We need to understand what a specific immune response happens to be and how we can distinguish that first and foremost from what we've already talked about in an innate immune system. Then once we finally get into the adaptive immune system, we have to look at the components. How we can divide it up: B cells, T cells, humoral immunity versus cell-mediated immunity. We'll look at the role that antibodies wind up playing, as well as look at some of the subcategories of the different cells that are going to be involved. The B memory cells, the T helper cells, the T cytotoxic cells, and we'll bring up some cells that we've already talked about, like our natural killer cells that were involved in our innate immune system. So when we compare where we are now to what we've already discussed, remember the innate immune system was non-specific. It wasn't there to target any particular foreign invader. It was an obstacle course. It was a gauntlet that's put in place to make any invader trying to enter the body's life a little bit more difficult. We had the skin and we had the mucosal linings with varying presence of pH changes, bactericidal agents that would not only slow down the progress of anything trying to invade, but put that invader in an environment that was non-conducive to it even surviving. So you reduce the dose effect of anything that happened to get into the body. If we do manage to get something cross that barrier, jump that fence, then we had any number of chemical mediators that could respond. Interferons, different chemicals involved with the inflammatory process. But again, all non-specific. It's when we get into the adaptive immunity where we are dealing with, generally speaking, a recognition of a specific foreign invader and then a targeted response. The result of that, in many cases, is going to be a long-term immune response, so that we respond to it on the initial exposure, and then any subsequent exposures we happen to encounter, we can respond more quickly and with a greater show of force, so that upon the second exposure, we never even get an infection that would even mount to a symptomatic response. So everything we've talked about so far, non-specific defense mechanisms. But we do start to see here now where we do get overlap. It doesn't mean that some of the chemicals that were involved in our innate immune system can't also play a role in a cell-mediated response or a specific response. It doesn't mean that some of the cells that are present can't also play a role in a specific response. We can see our inflammatory process trigger a specific response. So it's not like they're two worlds that never collide. They are interrelated, and I like to think of it as our innate response sets up our more specific response to be more successful. By having an innate system present, a barrier, we get a lower dose of infective agent that eventually has to be dealt with by a specific response, setting it up for a greater success. Because we're dealing with a more complex mechanism, a recognition and then a subsequent response, that takes time. In a way, our innate immune system can buy us that time. It's rapid, it's ever present. And it can slow down the advances of a foreign invader to give our more specific responses a little bit time to catch up. So we're really talking about our body's third line of defense here. Antigen specific. The antigen, you've heard that term when we talked about the red blood cell. We're going to use the term antigen here with respect to immune. And we kind of warned you back then. When we talked about blood typing, we had an antibody-antigen potential interaction there. What we had there was a protein found on a red blood cell that could potentially be bound to by antibodies. Here we're going to be looking at glycoproteinous structures on infected cells or as part of toxins from other bacteria. This third line of defense has to have a memory. This is really the component that makes it what it is. But the ability to recognize something, attack it, and then remember what it was for the next time it comes back around. And then finally, it has to be systemic. We did note that our different parts of our innate immune system was very much regional. This has to be full body, full systems. Anytime we're talking about an adaptive immunity, like we said, has to have an antigen specific. That's the whole point of this adaptive immune system, is that it has to be specific for a particular invader. But we're going to adapt in case, even if we haven't seen that invader before, we're going to get to know it quickly so we can remember it for the next time it comes back around. There are going to be two major branches that we'll get into. We'll talk about humoral immunity, which we'll talk about that being B cell mediated, antibody mediated. And we have cell mediated immunity. That's going to be more T cell involved. The third line of defense has to come after any surface barriers, after an inflammatory process. And because of that, there is going to be a time lag every single time. So as I said before, I like to think of the first and second lines of defense meant not only to help stop invaders, but also help to buy some time for a more effective specific immune response. When we look at the components that are going to be involved here, obviously we're talking about immune lymphocytes, but particularly B and T lymphocytes and their respective subclassifications. The B lymphocytes, as I said, is involved with the humoral immunity that we mentioned earlier. The T lymphocytes are going to be involved with the cell-mediated immunity. And if you remember back to when we did our blood composition, we talked about lymphocyte production, leukopoiesis. And we even mentioned some B and T cell differences even there. Both are going to originate in the bone marrow. as immature lymphocytes. The T cells, however, are going to become immunocompetent and mature in the lymphoid tissues, such as the thymus. B cells are going to continue to become immunocompetent and mature in the red bone marrow, but then they will both be released into the system, involved with the lymph nodes and the general circulation. So we have to have a cellular component. That's your half of the bargain, basically. The other half has to be provided by the invader, the antigen. And again, we mentioned this when we did red blood cell typing. We had the opportunity for an antibody-antigen interaction with red blood cells. Now, of course, we're not going to be only talking about antibodies and antigens here, because we also have to have our T cells involved, non-antibody responses. But the antigen is what's going to allow us to detect and recognize a specific invader and memorize what that antigen actually happens to be for subsequent exposures. We can have endogenous antigens. Endogenous means from within. These could be proteins that are produced by your cells, such as cancer cells. These could be proteins that are presented on the surface of a cell based on some cellular process, like phagocytosis. We break down a bacteria, we present part of its cell wall to the outside of the cell that had engulfed it, and recognize those antigens in that manner. Exogenous antigens are ones that entered the body from without. So think about an immune response you may get with a cat allergy, being inhaled, ingesting a shellfish protein and having an immune response, or even what we wind up getting with inoculations. We inject an inactive strain of a virus. We inject a toxin that may be able to be recognized, and then we mount an immune defense after that. We also have self-antigens. And again, I don't want to keep coming back to mentioning the same thing, but remember what I warned you in the beginning. We're going to be throwing out topics, getting into them in detail later, and having these terms bounce back and forth. So it's helpful to be familiar with the big topic before you get into the details. We're all aware that our own naturally residing cells and tissues have proteins on their membranes. These are self-antigens. Now, we don't want to mount a defense against our own proteins, just like we would not want to produce anti-B antibodies in a case of someone who happens to have type B blood. But of course, that really is a bit of the premise of an autoimmune disorder, where we do start recognizing naturally occurring antigens as foreign invaders and attacking them as such. In many of the types of responses we'll talk about, we have antigen-presenting cells. And again, macrophages, phagocytes. We engulf a bacteria. We present a part of that bacterial cell wall to the surface of the cell so that then they can be recognized and an immune system response can be adapted to that particular antigen. We mentioned major histocompatibility complexes when we did innate immune system, not because of its role in innate immune system, but we mentioned natural killer cells. We mentioned how they have the ability to attack a cell before any of the rest of the immune system can even recognize that it's an invader. They detect stressed cells without any formal presentation. Part of that presentation could be a major histocompatibility complex. It's these proteins that essentially allow us to distinguish self from non-self, foreign antigens versus self antigens. Now, we'll see two different classes of major histocompatibility complexes, and the first time you watch this lecture, just get a gist for what they are. Second time around, you'll see how they relate to exogenous versus endogenous antigens. Now, this diagram is a little busy, admittedly, but I'm going to try and pick apart here what it is actually showing you and put it into context of the terms that we've already discussed. This is a response against the exogenous antigens, the ones that would have been inhaled, eaten, vaccine-induced. You'll notice that the exogenous antigens are always going to be involved with our class 2 major histocompatibility complexes. But let's look at the general process here. Here we have our phagocytic cell, the big purple circle. We engulf an antigen, whether it be a toxin, whether it be a bacteria. We merge it with a lysosome and break it down. We take a portion of that antigen, and using a class 2 major histocompatibility complex, we present that portion to the surface of the cell, where now it can be recognized by our T cells that we'll talk about as part of our cell-mediated immunity. So we attack it, we break it down, and we present it now so that our other cells can recognize it. This phagocytosis may have been part of the innate immune system, setting up our adaptive immune system for recognition and ongoing immunity down the road. Similar, different diagram. We engulf an antigen, we break it down using a lysosome, we present it to the surface using a major histocompatibility complex, and then we get recognition. Any cell that undergoes this sort of process is going to be considered an antigen presenting cell. The endogenous antigens, the process doesn't really change that much, just the players are slightly different. This time, maybe we have an infected cell producing these viral peptides that would shed. We can present these to the surface, this time by a class 1 major histocompatibility complex. But if you notice, the process is still similar. Now we get our recognition by our T cells at this point. So where the antigen began may be different. The distinct players may be different, but the general process is quite similar. And this diagram will just show both types on the same diagram. A bacterium undergoing a phagocytosis, that's going to be an exogenous antigen processing by way of a class 2 major histocompatibility complex. We have our endogenous antigens and our class 1 major histocompatibility complexes. But the general gist of the process is going to be the same, and that's what you need to take away from the first time through here. We also have what we consider superantigens. Now, these superantigens don't present to the surface of the cell quite the same as our exogenous or our endogenous did. They bind to a more variable portion of our major histocompatibility complex, the TCR, T cell receptor proteins. And because they bind to the more variable portion, we can get a more general shotgun approach, if you will, to a response. This sort of antigen and how it interacts with our T cell receptors and our major histocompatibility complexes brings about a much quicker and much larger immune response from the T cells specifically. Here would be a typical endogenous antigen bound to the major histocompatibility complex. Here is going to be a rendition of what it might look like if it was bound to a more variable portion. Much larger immune response. We will see these sort of responses induce a much larger chemical response, drawing more agents to the area through that positive chemotaxis that we mentioned back in the innate section. As mentioned earlier, we have our two major subclassifications of adaptive immune. Our humoral immunity, using our B cells and our antibodies, and our cell-mediated immunity, using the variety of T cells. Now, because we're using antibodies in our humoral, I normally try and describe this as more of a long-range fight. B cells get exposed to the antigen. They start producing specific antibodies that go into circulation. The cell-mediated are much more of a hand-to-hand combat. They recognize, they bind to the foreign invader, and very often they will be cytotoxic. They will secrete chemicals that will destroy that foreign invader. So up close and personal versus producing antibodies and throwing them into general circulation. So if we just do a quick compare-contrast, B cells, B lymphocytes for our humoral immunity, T cells for our cell-mediated, always using antibodies for our humoral immunity, no antibody production for our T cell. Antibodies, we generally give them a Y-shaped molecule. Now, when we did red blood cells, we talked about IgG versus IgM and the differences. But we tend to see different regions now. Let's not just look at them as far as the shape. Let's look at what that shape actually refers to. Every Y-shaped molecule that we attribute to an antibody is going to have an antigen binding fragment. We're going to call that the Fab portion. It will also have an FC portion. It's a crystalline fragment that's going to interact with inflammatory cells. Now, these inflammatory cells are our own cells. So if we look at what that means, here is the branching portions of the Y, if you will. This is our Fab portion. That is what's going to interact with the antigen. Our FC portion, I guess, is the stem of the Y. That has the opportunity to bind to our own inflammatory cells. A mast cell would be a good example of it. You should know the different portions of the antibody. So when it comes to labeling where the Fab portion, where the FC portion is, put a star where the antibody would interact with the antigen. Now, of course, they come in, well, I shouldn't say many different shapes and sizes. The layperson is going to look at this and see an awful lot of the same, right? General Y portions with our Fab component, with our FC component. Each of these antibodies is going to play a specific role. So we're going to be able to attribute different types of antibodies to different types of immune responses. Not much different than what we did with our white blood cells previously. We said that our neutrophils were phagocytic specialists. We had our eosinophils responding to parasites. Here's our IgG antibodies. These were the type that were involved with our rhesus factor in our blood typing. Here's our IgM antibodies that were involved with the AB antigens. So the IgG are the most abundant. Most abundant. They're going to be the ones that are going to provide an awful lot of the immune protection for newborns. And just based on what you know now about blood typing, that should make perfect sense. Remember, the IgG antibodies were capable of crossing that placental lining. So any antibodies that the newborn may have came from mom because of that ability to cross that placental lining and enter into fetal blood. We have our IgA antibodies found in body secretions. Again, you want to bring mother-infant into the mix. We can secrete IgA antibodies as part of breast milk. And now we can relate this to even an innate immune response. Now that breast milk is going to linger in the newborn's mouth, line the esophagus, and be able to interact with any antigens that happen to be in the oral cavity or even down into the stomach. So we're not talking about distinctly totally different topics here when we go from innate to adaptive. We had our IgM, again, part of the AB antibody or antigen recognition when it came to blood typing. These can be made prenatally. Remember, they don't cross the placental lining. So any infections that do occur in the womb may still get an IgM response, but those are going to be because they're produced by the fetus. We see IgD antibodies. They're going to act as receptors. They're going to be found on B cells that can bind to an antigen, and then subsequently the B cells can produce even more antibodies to respond to that particular antigen. And then lastly, we have our IgEs. Going to be involved more so with the eosinophils, allergic responses, and particularly against parasites. Now, with these antibodies, we can have any number of actions. We can have a direct effect where you can affect the infectious agent or their toxins directly. The antibody can neutralize the invader, bind it up, and prevent it from binding to the receptors for early entry into the cells. We talked about agglutination reactions with our blood typing. Multiple bindings onto an antigen causing a clumping together, rendering that particular antigen ineffective. Or a precipitation. You bind to it, now it's less soluble, takes it out of solution. Either way, it's directly attacking that antigen. Other times we get more of an indirect effect, where we bind and we're only part of that recognition process. But the Fc portion will now bind to one of our innate cells, while the Fab portion had bound onto the antigen. Now, we mentioned that process as opsonization back when we did innate. Complement activation with our MAC formation. Here we see examples of that when we see our antibody bound to a bacterium, basically creating a bridge onto a macrophage. Now we engulf this, and we've disposed of it. We see an example of an indirect here with our IgG function. To see how we can get interactions between the antibodies and the various cells. We have a parasite that's invaded the body, starts producing these parasitic antigens. It's recognized by a B cell, which then produces antibodies. The Fab portion of the antibodies will bind to the antigen. The Fc portion of the antibodies will bind to our mast cell, secreting chemicals, in this case, eosinophilic cellular factors, recruiting eosinophils to the region, which can then attack the parasite directly. We can classify our antibody actions not only by indirect and direct, but also internal versus external. When you think about antibodies, you're probably already thinking internal. In the circulatory system, meandering about looking for something to attack. The external would be a good example of what we talked about with mom's breast milk, lingering in the mouth and down the esophagus of the newborn. Antibodies that may be in the mucosal lining. Any secretions that may be in the mouth or nose. We see monoclonal antibodies, and these have been kind of, I shouldn't say at the forefront, but involved with treatments of things like cancer, immune responses to cancer. They can be produced in a laboratory from one B cell that's been cloned, get all the antibodies that are in the same class for a very specific response. And if you think about the adaptations that we could have for cancer therapies with regard to this alone, this is not the only immune adaptation for cancer, but it's a good one to bring up. It's been around for a long time. But when you think about the common treatments for different cancers, radiation, chemotherapy, surgery, all extremely invasive. If you find a tumor that needs to be dissected out, you'd better hope that that tumor is well defined, clear margins. If not, surgery may not even be a pertinent option, let alone if you have to cut through vital tissue in order to get to it, making it inoperable. Radiation can be devastating to those various regions of the body, let alone the tumor might be hiding behind organs that you might not be able to radiate. And of course, we all know the devastating effects that chemotherapy can have on the body. But if we can somehow adapt an immune system response specifically to antigens that may be on the cancer cells, now you've got essentially a magic bullet, so to speak, where you would have an immune response specifically to those cells, and you would have zero consequence to any unaffected cells. Now, when we look at how these types of immunity can carry on to give long-term protection, we'll do the same thing after we look at cell-mediated immune responses as well. We're still in the humoral section here now with our B cells and our antibodies. But one of the things that we said were most useful for our adaptive response, not only is the ability to attack an antigen specifically, but to remember that it's been here so we can mount an immediate response the next time it shows up. We can break the process down into a primary response, first exposure, and a secondary response, subsequent exposures. Now, the time frame in here, you can see, it can be years later on this particular diagram. But in all honesty, how effective the secondary response is going to vary based on the antigen. Certain things that you've been vaccinated for, you are no longer immune to. However, now that you're an adult, contracting that particular agent is not a high risk. It was when you were 6 months old. It's not now that you may be in your 20s. Other things, an immune response will last decades. So it really is variable based on the antigen that you happen to be talking about. But that's neither here nor there. When we see our primary exposure, we get recognition by our B cells. Then the B cells start to proliferate. Proliferate means to divide, mitosis. The immediate response is going to be this replication into plasma cells that produce antibodies to fight the invader that was just recognized. But we also go through a clonal selection. This is what we're going to call a memory B cell or a B memory cell. This cell is going to have antibodies embedded onto its membrane and will continue to be in circulation for, as this diagram indicates, up to years later. So now, even after the initial infection's been fought off, these B memory cells are still in circulation. And now, if that invader comes back around, we're ready. And this B memory cell can immediately clone plasma cells to up the production of antibodies, as well as clone into new memory B cells. We'll see a very similar response when we look at clonal selection for T lymphocytes. The cell-mediated immune response, remember, it does not involve antibodies. Much more up close and personal. And we've got a larger selection of cells that are going to be involved here. The ones that we'll talk about as far as being the main attackers are going to be the T cells, the cytotoxic T cells. T helper cells are going to be activators. We didn't mention it yet, but we even see T helper cells involved in our B cell activation. Part of this process here of triggering antibody production is going to be activated by the presence of a T helper cell. And of course, we also have memory cells involved with this process as well for that long-term immunity. When we look at the different functions that these T cells take on, cytotoxic, if you look at what that term implies, cyto, cell, toxic, speaks for itself. Secreting chemicals onto an infected cell, onto an an invading organism, even a cancer cell, and becoming toxic to that cell, destroying that cell. We had our natural killer cells. We said those were involved in our innate as well. Didn't require a particular antigen to be present. That doesn't mean they can't respond to a cell that does have a particular antigen present. But they are going to be less specific, so they can still respond to a wide array of antigens. So when we look at the mechanism that could come into play here, we look at this this illustration. It's going to call it an animation, but it's an illustration. We have our T cell receptor protein binding onto an antigen, which adheres it to the invading cell. We secrete our cytotoxic agents, destroying the invader. Natural killer cells will take on a very similar role, just not quite as specific for the antigen. For our T cells, our cytotoxic T cells, we needed this presentation of our antigen. Our natural killer cells did not require that. We activate macrophages, so we can still have a phagocytic response that's specific. We can still release chemicals like cytokines that were still involved with our innate response to activate macrophages, but this time for the purpose of recognizing a specific antigen. And of course, we said earlier that the T helper cells are activation cells. They're going to help regulate and moderate any sort of specific immune response, not just the cell-mediated, with it being a T cell, but T helper cells also help regulate antibody production from the B cells. So let's look at some clonal selections now for our T cells. Very similar manner to what we saw in B cells. A recognition, a T cell, helper cell, or cytotoxic. Helper cell over here on the left, cytotoxic on the right. A recognition, a springing into action, if you will, with now the helper cells secreting chemicals that can activate our cytotoxic T cells or our B cells for a humoral response, but also the cloning of these memory cells that are able to give us a much earlier detection. We no longer have to go through the processing of recognition. Saves us time, allows us to fight back before any sort of infective agent can get a foothold. So if we step back and kind of look at bigger picture processes now, in phases, if you will. If you want to talk about how to get a general specific, in general, a specific response, it helps to have a wide array of players on the field first. That's our clonal diversity. Even before birth, you do begin maturing your array of T cells and B cells. Different ones to target different antigens. Now when we get the introduction of a specific antigen, what those diverse cells that were already on the field are going to do is respond. Now you're going to get antigen presenting cells. Recognition by your T helper cells, activating B cells to produce your antibodies, activating your cytotoxic T cells to respond with a cell-mediated immunity. And you get a proliferation at that point of the specific type of cell, right? You had a wide array of diverse cells back here in our first phase. But now you increase the proliferation of the specific type of cell that happened to be involved with the specific antigen that was just introduced. The B cells become plasma cells for that initial infection, start secreting antibodies. Memory B cells are going to be produced at that same time for long-term immunity. By now, the cytotoxic T cells would have become activated as the T helper cells would have recognized the invader and activated the cytotoxic T cells to have a response. Now, if we look at that in a timeline, this is kind of what we would see as far as antibody production. You have your first exposure. Now, we didn't mention this, but IgM antibodies tend to be produced earlier after a response. So they will elevate, slightly followed by the IgG antibodies. You will fight off your infection, and life will somewhat go back to normal. Now, this period between here, and maybe months, maybe years. But on the secondary exposure, now, because of the presence of your memory B and T cells, you will still get a response similar to what you had on the initial exposure with your IgMs. This curve and this curve were rather similar. However, your IgGs that are now circulating as part of that memory system will not only escalate quicker, notice how they get out ahead of the IgM antibodies this time, but the degree at which they play now, much higher titer of antibody levels than you would have ever seen on the initial exposure. So just because you're immune to something doesn't mean that agent can't enter the body again. If you've had chickenpox or you've had the chickenpox vaccine, it doesn't mean you can't be exposed to someone else with chickenpox and have those viral fragments enter the body. But because of the rapid and sizable response, we don't see that virus hijacking innate cells and proliferating through the body again, like it might have done first time through. So the last topic we have to get into is active versus passive immunity. When you consider these two terms, always think about it from the perspective of your body doing the actions. For active immunity, your body, your cells, did the heavy lifting. Passive means somebody else did the work and simply gave them to you. Now, this will make more sense once we look at some examples here. Passive immunity could be the antibodies that were produced by the mother and either given to the fetus prenatal or as part of the breast milk. Mom produced those antibodies and gave them to the fetus. So when we say it was passive on part of the fetus or the newborn. If you have certain autoimmune disorders, you may go into a hospital for a routine gamma globulin dose, or they will hook you up to an IV and a big bag of gamma globulins, and you will get these antibodies injected into your circulatory system. Again, you didn't make those. You acquired them passively. However, if you catch a disease, if you catch chickenpox, as I record this, we're still going through COVID vaccinations, and the length of time and subsequent immunity after exposure is still a little bit to be determined. But if you catch the pathogen, now you are the one that's actively responding. You're the one producing the antibodies. You're the one mounting a cell-mediated response that is active on part of your immune system. And of course, we can induce that artificially as well with something like a vaccine. You're the one still responding to that, I guess in this case, a more controlled infection, to use the word infection more loosely. When we think about pediatrics, a lot of a newborn's immune system is going to be by way of mother. IgG antibodies that have crossed the placental lining, IgA antibodies that were part of breast milk. Once birth has happened, you do see a slow increase in child's own production of IgG antibodies. The IgG antibodies from mom are going to be at a peak right at birth and then slowly decline. Now, what antibodies are present and what immune agents are going to be present is really the reason for the inoculation schedule. Right? You have a routine vaccination schedule, and typically you get this one at this point, and that one at that point, and that one at that point. So when you consider why a baby or an adolescent gets a certain vaccine at a certain time, it's a combination of factors. One, how detrimental would it be for that particular individual to catch this particular infection? So you want to inoculate maybe as early as possible in some cases. But you still have to have the immune agents present naturally to use the vaccine appropriately. Remember, a vaccine is an active process on behalf of the person getting it. You inject the antigen, a low dose, an inactive strain. Then you mount a response based on it. Right? The flu vaccine is a great one for that. People say they got the flu from the flu vaccine, but in reality, that doesn't happen. The vaccine is an inactive strain. Now, you could get flu-like symptoms after the vaccine, because a lot of the symptoms you would get is your body's immune system's response to that influenza virus. Just because we injected you with an inactive strain, we did that so you could get an immune response. You just won't have the flu to pass it on to anybody else. So you still have to have the agents involved. And if you notice early on, we may not have the apparatus, so to speak, to take advantage of certain vaccines. So some have to be put off till 10 years old, till 12 years old, depending on when in the developmental stage you would be able to respond to what's being injected. And of course, if we look at the other end of the spectrum, right, they often have a saying that goes with epidemiology and infective agents, and it's a little cold to phrase it like this, but when we think about infective agents, they kind of say that the newly bred and the almost dead. That's when you're going to be most vulnerable to mounting an immune response. The thymus, where we talked about a maturation site for some T cells, reaches its maximum shortly after puberty, and then it's all downhill after that. As the individual gets older, you tend to see a slower immune response, a less robust immune response. Not to mention some of the things that may have been exposed to earlier on now isn't quite as effective because we've exceeded a certain timeline. So elderly people typically become deficient in T cell production. Makes them at much greater risk for most every infection. And of course, again, as I record this, we're still kind of knee deep in a pandemic. The people who were most vulnerable were obviously the people with certain pre-existing conditions, but also the elderly. And the last topic we'll bring up as a bit of a tangent could be organ transplants. Think about what happens if someone has to have an organ transplant. They need a match. They're still talking about antigen immune response interactions. We mentioned earlier, you have self-antigens. You have proteins and glycoproteins on your cell wall that are part of your normal composition, and you generally won't produce an immune response to those. So not only does your immune system has to recognize the invading antigens, but they have to be able to distinguish those from your self-antigens. Well, it is not going to be a successful transplant if your body recognizes the antigens on the transplanted tissues as a foreign invader and attacks it as a result. That's when they would use terms like, oh, they've rejected the donation. Now, certain organs, again, not exactly my area of expertise, but certain organs require a much more specific match. It's my understanding that a lung doesn't really have to be that specifically matched, given the nature of that tissue. Kidney, not necessarily that hard to find someone with a kidney donor. However, something like bone marrow can be extremely difficult to get a match. And if you don't find a match in the immediate family, the hopes of finding a match diminish quite a bit. So again, watch this lecture once and just kind of take it in for a bit. You saw how we jumped from certain topic to certain topic, at least a little, and it was somewhat unavoidable. To talk about what this third line of defense happens to be in general terms, the different types of specific adaptive immunities, the different types of cells involved and how they can play roles on multiple stages. Now, when you go back and watch it second time through, it'll immediately make more sense as to what's what. So as usual, if you have any questions, please reach out, and we'll be discussing this topic more as we get even into the other systems. Take care.